Hi, I'm Dr. Donald Jurivich, and I'm a UND professor of geriatrics. And today we're going to talk about age-friendly healthcare. This is part of a program guided by the HRSA-funded Dakota Geriatrics Workforce Enhancement Program. So I'd like you to consider this pre-test question. Please pick one of these four. The geriatric 4 M's are move, meditate, medicate, maximize. Answer B, medical condition, mood, mindfulness, motion. Answer C, what matters most, mind, medications, mobility. And then answer D, manage, milieu, money, meaning. Please make your selection. Thank you. Older adults in healthcare is an important consideration because 20% of the population consists of individuals 65 years and older. As people get older, medical complexity increases, and as the population moves forward with older individuals, 1 out of 3 have 4 or more chronic conditions. And then finally, the vast majority of medical care and costs are consumed in the last years of life, often in futility and not being necessary. So we want to consider the overall picture of older adults in healthcare. They commonly have high medical complexity. Sometimes there's frailty. And overall, older adults are susceptible to medical complications that includes falls, other adverse events such as medication side effects. So the question is, if you could provide better care for older adults, what would you do? So here's a case report. We have a 99-year-old female, retired clergy member who lives in a nursing home. She's become bedbound and reports worsening pain in her back with a history of multiple past osteoporotic bone fractures. She says that she is at peace with herself and God. She states that she endures about 8 out of 10 level pain, and she feels that this is her penance, but does hope that the angel of death will soon visit her. She's dependent in all of her activities of daily living except feeding. She now has a dry cough and low-grade fever. How would you match her healthcare plan going forward with what matters most to her as revealed in this case report? So we'd like to set this up as a case presentation to think about as we go through the framework of what we call the 4 M's. So we want to overall provide better healthcare for older adults, and to do so we have to follow best practices. And we have to apply these best practices consistently. And then finally, we want to evaluate and look back and reflect as to whether these practices are working for our older adult patients. So that comes to this concept of what I mentioned, the 4 M's framework. These are called the geriatric 4 M's, and they are as pictured here on the right side of what matters, or what matters most: medications, mind or mentation, and mobility. And in a strong, older adult-oriented healthcare system, these 4 attributes, or these 4 elements, need to be delivered reliably with each encounter with the older adult across the continuum of healthcare. So how do we get to the goal of providing better care for older adults? Well, firstly, we have to always be vigilant and improve our knowledge in geriatrics and our skills. And then secondly, we have to apply this knowledge through what we call geriatric assessments and action plans. What kind of knowledge do you think we need? Well, there's a lot. And just in a nutshell here, we need to be able to recognize or diagnose atypical presentations of common diseases. Sometimes pneumonia, for example, presents as abdominal pain. Did you know that there's 2 kinds of delirium? So this is what we need to know and distinguish between those two. How about being able to identify depression and or loneliness? We also need to understand certain geriatric syndromes, such as falls, frailty, memory loss, and urinary incontinence. It's also important to do a fair evaluation of remaining life expectancy so that older adults can better plan for their remaining lifespan. And then finally, we all want to be able to protect vulnerable older adults from harm. So the question is, how do we assess each of these 4 M's? And so we start off with what matters most. And that often at its very basic level is assessed by the advanced care plan, or what we call the PULSE, the physician orders for life-sustaining treatment. There's the living will, there's a durable power of attorney. But really, the meat of this whole question is asking what the older adult, what matters most to them. In terms of mind, or some people call it mentation, we use very short screening questions such as the PHQ-2 for depression screening. We use a very short form called the mini-cog for memory loss. And there's some scales for measuring social isolation and loneliness. And then finally, for delirium, we have either the ICAM or the CAM, the confusion assessment method, or the new desk, which is the nursing delirium assessment. In terms of the 4M of mobility, we do balance testing, such as putting one foot in front of the other, and we call that the Sharp and Romberg test. We may also use gait speed, because if somebody walks less than a meter per second, they have a high fall risk. In terms of medication, we use checklists to look at whether there's some unsafe medications for the older adult, or maybe they're taking too many. So if you look at these screens, you've either got they're what we call screen positive or screen negative. So if somebody, if you ask what matters most, and if you find out that they screen positive for not having an advanced care directive, you ask them to get their advanced care completed and give them educational materials about their advanced care plan. In terms of if they already have an advanced care plan, then you ask them to consider to revise it, update it, and further discuss it with their family members. In terms of evaluating the mind, we want to look at delirium. And so if there is delirium, there's certain protocols for dealing with acute confusional states. There's also protocols for dealing with memory loss, particularly for behavior, and we'll discuss these in this series of presentations, as well as depression, which can be treated both medically with medicines or non-medical interventions. And then also, if you're screen negative, so if somebody has a negative PHQ-2 test, for example, for depression, how do you prevent depression? And so those are some of the things that we need to consider as we look at these 4 M's. In terms of the mobility plan, if somebody screens positive for a fall risk, in other words, they were wobbly on their tandem stance, then you know that they're a high fall risk, and you want to ideally refer them to a fall team. And in the absence of that, or in addition to prescribe core balance training for them. And likewise, if they do pretty well on those tests and are what we call screen negative for falls or fall risk, then we want to prevent future falls by prescribing a core balance training program. In terms of medications, a positive screen for unsafe medications would lead to a deprescription process that may occur through a pharmacist and or primary care provider. And then also being very vigilant if the older adult is not taking unsafe medications, then to make sure that a provider does not prescribe unsafe medications unless absolutely necessary. So to summarize, to provide better care for older adults, we want to assess the 4 M's, then we want to create an action plan for each 4M, and that involves the whole healthcare team, by the way. And ultimately, each of us want to be an agent of change for better older adult healthcare by practicing these 4 M's consistently and documenting them in the medical record and discussing them ongoing with both the healthcare team, the patient, and their family. Thank you. And this is the post-test question here. If you can complete that, please.